I will be making a quick introduction on MindEar, and then we'll introduce our speaker today. So for those that join us and never heard of MindEar before, we are a platform or a service provider for tinnitus. People that suffer from tinnitus usually have many questions or many problems that we try to address, and we try to help them manage the symptoms and the impact tinnitus can have on their life and provide tinnitus relief. We do this in multiple ways. One of those ways is through our evidence-based app. We've developed the MindEar app over a few years, and we've combined all the techniques that have been shown to help with the impact of tinnitus. These include cognitive behavioral therapy. So this is the way where we can change your reaction to the tinnitus, and that helps mostly with sometimes the stress and anxiety that comes with the condition. We also have soundscapes. So this is useful for sound therapy. Applying sound therapy can provide short-term and sometimes long-term relief from the tinnitus, and it can be done in different ways. We use nature sounds, noises, and neuromodulated sounds that can help provide you with relief. So it's very interesting. And then we also use relaxation and mindfulness, which have been shown to help manage the stress that can happen in anyone's life, but especially when tinnitus is involved. And this has been shown to help with the tinnitus impact as well. And we also provide a lot of information for you that are looking for some kind of specific topics. The webinars like this, where we go into different specific topics around tinnitus and try to explain and unveil a little bit what's happening. So who are we? We are a team of experts. I'm Dr. Mathieu Cunha. I'm one of the co-founders, but we work with people all around the world that have been dedicating a lot of their time and efforts to this problem. We're very lucky to have research collaborators from different countries also involved in this project and its business. So I won't take too much time introducing them, but they're really at the forefront of this tinnitus research. So we're very lucky to have them participate in our work. We also recently introduced our group coaching products, which is basically a way to go a little bit deeper into helping people by providing some structured sessions. It's about 12 weeks long, 6 sessions. So every 2 weeks we meet for an hour or 2 hours, and we go into those specific techniques and go really much more in detail. We talk about finding the mixing point in sound therapy, maximize the effectiveness of sound therapy, or how to apply cognitive behavioral therapy to your problems, how to change your own reaction to the tinnitus. These sessions are fantastic to meet other people that have similar issues as well. So it's always also about the community and making you understand that you are not alone. And that's a very important message that we always try to make come through. These are available on our website. I will share a link later on. You can register and get started with us as soon as the next session comes up. These sessions are rolling, so it doesn't really matter where you come in. We then take you through the whole structured program from there. You can also download the app. I'll also share a link later on in the chat, and hopefully that will be something where you find some value. Okay, so now I'm very lucky to introduce our speaker. The topic of today's webinar is pulsatile tinnitus. I'm not too sure how many of you have been talking to us directly online. If you've met anyone from the MindEar team, one of the first questions we ask is, have you been to an ENT? Have you had your ears checked? And some of the reason for that is like tinnitus is very complex. There is always a lot going on in the background. There's so many questions that can be asked and so many things that can happen. So one of those things that can happen is sometimes your tinnitus might sound pulsatile or be in rhythm with your heartbeat. And that's a very specific problem or a very specific issue that can sometimes be explained by other reasons than just an abnormality in the ear. So for today, I would like to introduce Dr. Axon, Patrick Axon. He has been a consultant ENT surgeon at Cambridge University Hospitals since 2001. So he's been working on this for a very long time, and we're very lucky to have him. His practice covers all pediatric and adult otological issues, and he has extensive experience in managing various forms of tinnitus, and especially pulsatile tinnitus. He has played a key role in developing the East of England hearing implant and skull-based services, now among the largest centers in Europe. Dr. Axon is the president of the British Skull-Based Society and a member of the British Cochlear Implant Group and the British Society of Otology. He's everywhere. He frequently presents research at international conferences as well, and we are very delighted to have him today with us. Okay, now to you, Patrick. If you want to share and start, I'll put myself on mute. If there's anything, just let me know, and I'll come back online.
Perfect, Mathieu. Thank you very much. Let me just get the thing up. Hopefully, let me just. There we go. Can you see my screen? Oh, okay, great. So, Mathieu, thank you very much for inviting me along today. It's a real pleasure to be able to talk on a subject that I've spent 20 years investigating. And it all started with some patients who presented with pulsatile tinnitus, and I really didn't have a clue what was going on. So I decided to do a bit of research, and that's with everything, and the internet and forums, people heard about my interest. And so I've ended up seeing quite a few patients. So I'd like to start with an overview of what I'll be talking about. And I want to talk about what pulsatile tinnitus is, although Mathieu has already told you a little bit about that, a little bit about ear anatomy, the different causes, how they present, the investigations of choice, and treatment options with outcomes. And then hopefully at the end, this should take about 40 minutes, hopefully at the end, we'll be able to have a question and answer. So it's a perception of a rhythmic sound, and it's in time and varies with the heartbeat. It can vary in character between patients, so it can be low or high-pitched, whooshing, thumping, pulsing, ringing, hissing. There's lots and lots of different ways in which patients can describe their personal pulsatile tinnitus, and loudness perception is highly variable. Some patients really aren't too troubled, but others are. It can be heard in one ear, or it can be described as being in both ears or rising somewhere in the head. And lastly, it can be subjective or objective. Now, objective means that other people can hear it. So patients will often mention when they're in a quiet room that their partner or a family member can hear the noise emanating from their head. And if you listen with a stethoscope, sometimes you can hear it. And I'll play some noises hopefully later that reflect that. So pulsatile tinnitus can go to lots of different interests. So neurologists, neurosurgeons, vascular surgeons, ENT surgeons all can see patients with pulsatile tinnitus. And so it never really is seen as a home to one particular group. And more recently, interventional neuroradiologists have also become particularly interested in this field. It can be a mild nuisance, but for some it can dominate their life. And many patients are told that there's no cause to be identified, although reassured through the investigations they've been through. And one reason why a cause may be not found is that pulsatile tinnitus doesn't always have a vascular cause. And I mean that in the sense that the sounds they're hearing are not being picked up by their cochlea. And I can emphasize that because sometimes when I see patients who've got no hearing in my hearing implant clinic for cochlear implantation, they can also describe an awareness of being able to hear a pulsatile sound. Of course, they can't because they've got no hearing in their cochlea. However, it is important to identify those patients who have got serious risk, and it's a tiny group, but you do need to find them. You do need to identify them. So I've seen well over 1,000 patients with pulsatile tinnitus over the 20 years. And the information that I'm going to give you is all based around a group of around 800 patients that were prospectively covered. And these patients all presented to me with undiagnosed pulsatile tinnitus. That was their primary symptom. And some I didn't reach a diagnosis on for various reasons. Some didn't complete their investigations because when I reviewed the data, they hadn't quite got through the investigation protocol. Others reported their pulsatile tinnitus had resolved and so didn't need investigations. And others were reassured because either an MR scan was normal or previous investigations and my conversation with them reassured them. At about 3%, I wasn't able to reach a diagnosis. I suspect that those patients had either a venous or central cause, but the history and investigations and examination didn't allow me to be certain. So a quick review of the anatomy. This is an ear. There's the outer ear. There's an inner ear, a middle ear, and an inner ear. So I'm just going to try and get a pointer. Hopefully that'll work. Okay, so outer ear, middle ear, and inner ear. And sound passes down, hits the eardrum, goes through the ossicles and into the cochlea. The vibrations are converted into pulses that then run down towards the brain. And this is the blood supply to the ear. So it starts off in the carotid. You can see here the carotid with blood contrast passing through. And as we play this, you can see the blood passing through the head. So it goes up through the arteries, through the brain itself, and then drains out through the venous system back towards the heart. So that again, artery supply going through the brain itself, then coming out through the venous system and draining into the heart. So I'm going to split pulsatile tinnitus into three main groups. So it's an abnormal hearing organ that can hear normal blood flow, and that's usually pathology within the temporal bone affecting the hearing mechanism. And so the hearing mechanism breaks down, and not only does there a hearing loss, but there's also an awareness of normal blood flow. More commonly, you can have a normal hearing organ hearing an abnormal blood flow. So that's being picked up by the cochlea and the hearing mechanism and transferred to the brain, and it's a bruit that they're hearing. It's a disordered blood flow that they've become aware of. And then lastly, a significant group where the sound is being created by an abnormal hearing organ. Something's broken down in the auditory pathway, and so patients can hear an abnormal sound. This isn't a sound they're hearing through the cochlea, it's a sound that's being generated within the auditory pathway. So if I go through these quickly, this is middle ear. You've got the eardrum, malleus, incus, and stapes. And this system is exquisitely sensitive to the very minor air vibrations that hit the drum. And it's all designed to amplify the sound through this system and impart vibrations into fluid, which is within the cochlea. It amplifies it and sends it into this cochlea, which is here. And it's suspended by ligaments. So you've got a ligament here to the incus, the malleus, and there's tendons here to strengthen make sure the ear isn't damaged by extra loud noises by the stapedius muscle and the tensor tympani tendon and muscle. And so if anything is to touch this system, this apparatus, then it can impart a blood supply, either by the blood that's running through the thing that's touching it, or it's being passed via another area that's pulsating. And I'll give you some examples. So here we've got a dehiscence of the plate of bone that sits over the ear. And as a result, the dura and the brain, this is brain, white is bone, air is black, and this dura is fallen down and it's sitting on the malleus head. And you can see here the pulsations of the brain are being sent through to the eardrum. You can see the eardrum pulsating in time with the heartbeat. You can get something called otosclerosis, where there is bone formation around the base of the stapes, and at an early stage, patients can become aware of a pulsatile tinnitus before a hearing loss. That's pretty rare. The vast majority present with a hearing loss, but occasionally I see patients with otosclerosis. This is something that ENT surgeons always want to exclude, and this is a benign growth, a paraganglionoma. It's sitting behind the eardrum, It's a red, fleshy, benign tumor that has got a high blood supply, and this blood supply moves the hearing apparatus, and as a result, you can hear a whooshing associated with the hearing loss. It's not a high proportion of patients in my series. It's likely higher in the general population because it's quite easy to diagnose. So ENT surgeons will refer directly with a diagnosis of glomus tumor. This is a series where no diagnosis has been reached, so it's likely higher in the general population. And then you get real rarities. So this is an aberrant carotid artery that's crossing over the cochlea and imparting pulsatile sounds. That shouldn't be there, and it is. That's a congenital abnormality. It's from birth. And this is a pulsating jugular bulb. So this is a bulb of venous blood, and that should have bone over it, and it hasn't. And so the pulsations are being transmitted to the hearing mechanism. You can see that pulsating away. So those are middle ear causes. And then you have inner ear causes. This is the otic capsule, which holds the balance organ and the cochlea. And if sound comes in, as mentioned, through the stapes, which is attached to the oval window, vibrations pass into fluid. Fluid cannot be compressed. So if vibrations are to go into this system, they have to come out, and they come out through the round window. Occasionally, this system can get a third window, and if it gets a third window, then other vibrations and sounds can pass through the fluids into the hearing mechanism, so you can become aware of pulsatile tinnitus. And the commonest cause is something called superior semicircular canal dehiscence, and that's erosion of the superior semicircular canal. And you can see this on this radiograph where that should be covered in bone. It's not. It's got a gap, and sound can transmit through into the inner ear. These patients usually also complain of other symptoms, including autophony, which is an awareness of bodily sounds, particularly eye movement, blinking, and also something called tulio, which is where loud sounds can cause them to feel dizzy because the sound not only goes into the cochlea, but now can escape through the balance organ. Very rarely, the erosion of the superior semicircular canal can occur because of a vein called the superior petrosal sinus. This is incredibly rare, but can, in this situation, be present with a more dominant pulsatile tinnitus. Other areas of the otic capsule can be eroded. So here there's erosion of the lateral semicircular canal by this cholesteatoma, which is a collection of skin. This very rarely presents with pulsatile tinnitus because cholesteatoma doesn't have a blood supply, and so it shouldn't pass pulsations. But if the cholesteatoma was also to erode the skull base and it's attached and therefore connected to the brain, then it could impart pulsation. And I've got one patient with that. And then other rarities include erosion of the cochlea directly, either with tumor or with a carotid artery. So that's a quick review of temporal bone causes. They're not many, makes up about 9% of patients. So I want to talk about vascular causes. And I'm going to spend a bit of time talking about objective pulsatile tinnitus. So that's, as I mentioned, sound that could be heard by others. Now, if you have pulsatile tinnitus, it is really important that you have your neck, your head listened to with a stethoscope. A doctor should be listening to see whether it is objective. And if it is objective, then it needs to go down a different investigative pathway. And hopefully you're going to hear these sounds that I'm going to play. They're slightly different in character. So the first one is an arterial sound, and that arterial sound is recorded in the neck where the carotid is. And it's a particular type of sound. It's a ch, ch, ch. So it's a specific sound in the cardiac cycle, limited to the systolic, the ejection of the blood coming out. So hopefully you can hear this. So that is a ch, ch, ch. And you can hear that.
Doesn't seem like we can hear it really well.
You can't?
Unfortunately.
Oh,
no.
Okay. Okay, let's see if I can switch it up a bit and we'll see whether it works again. I'll play it again. If I can't, then I'm sorry, we'll have to move on. No, Okay, sorry about that. So they're different types, and they can present with different types of bruit, and these are recorded easily actually using an iPhone. So the importance of them is that sometimes they can lead to a stroke. Not always, I hasten to add, but it's important to find patients who've got objective bruit, find the underlying cause, and if it's a safe, then nothing to worry about, but occasionally it needs to be treated. So there's arterial causes, which are purely generated within the arterial system, arteriovenous, which are where blood goes from the arterial system directly into the venous system, and that leads to an awareness of a bruit, and so you get this sound, which is often recorded all over the head. You can often hear it at many places. And then occasionally you can get a venous cause, which is a lot softer and a whoosh sound that can be present, and it's just a very small part, a number of all patients who have got venous, but it can occasionally occur. And these patients need catheter angiography to identify the underlying cause. So in my series, nearly 9% of patients have got objective pulsatile tinnitus, and these are the reasons. So some of the arterial causes include carotid dissection, fibromuscular dysplasia, aneurysm, and some of those patients, if they've got that, need to be treated appropriately. Some patients have the dural fistula, and a large proportion of those are benign, nothing to worry about, but occasionally you can get something called cortical vein reflux, and that has a small risk of stroke over many years. And finally, as I mentioned, venous abnormalities, and one cause are abnormal venous outflow from the head. They find a new route to get out, and one of them is the condylar vein, and that, in my experience, can lead to an objective bruit. But I want to spend more time around subjective venous pulsatile tinnitus, which is where most patients sit, and also centrally mediated pulsatile tinnitus. So venous pulsatile tinnitus is a venous sound that's heard by the cochlea, and it predominantly occurs in females under the age of 40, and it's a low frequency whoosh, generally whooshing, thumping, banging, and 90% describe it as such. Nearly 90% can control it by pressure over the internal jugular vein. And often I'll have patients coming in, resting their hand under their jaw so they can hear me when I speak to them. And in this patients, particularly in young females, it can often also be associated with symptoms of raised intracranial pressure. So patients will often describe headache, head pressure, fogginess of thought, poor concentration, and they might have received a different diagnosis from other doctors, the commonest being migraine. So how is it generated? So blood enters the head and it circulates through the arterial system, through the brain, and down through the venous system. And in a normal person with no tinnitus, pulsatile tinnitus, that blood drops out of the head. There's no pressure gradient, it just falls out over the period of the cardiac cycle. But sometimes the blood just can't quite get out quickly enough because of a narrowing. It might be that the anatomy of the veins are slightly different. So there is a dominant one vein that gets blood out of the head, and that can be slightly narrowed, or the pressure inside the head can narrow the veins inside the head, so limiting flow of blood through. And with that being the case, the blood can't quite get out is within the time of the cardiac cycle. So when the next arterial blood goes in, because the blood comes up from the heart, it shoots into the head, then something has to give. And the pressure inside the head leads to the venous blood being pushed out, and there's a whoosh as the blood exits the head. And that can be heard by patients, and it's a venous whoosh because of driven by the arterial inflow. And many patients can have this as a result of narrowing of the venous sinus. Again, this is predominantly of young females. They've got narrowing of their transverse venous sinus, and this can often be associated with other pathology within the temporal bone. So you can have something called sigmoid sinus dehiscence or a diverticulum, jugular bulb pathology. I showed you a picture of that earlier on. Some patients have thrombus formation within the venous system, and so that limits blood escaping the head. And then lastly, you can have some narrowing of the internal jugular veins, which I'll come to at the end. So here's transverse venous sinus stenosis, arrows pointing, so the blood is coming through the sagittal sinus going to each side, and there's narrowing here. You can see the narrowing. So blood is having a little bit of difficulty getting out of the head past those areas of narrowing. This is sigmoid sinus dehiscence. There should be bone covering the sigmoid sinus. That's the sigmoid sinus brain. This is the temporal bone. The ear is here. So blood is being squirted through the sigmoid sinus in a pulsatile fashion. The sound is escaping through this gap and is being heard within the cochlea. And here's a schematic showing that, the sound going through the hearing mechanism. Another cause is diverticulum. So here you've got an outpouching of the sigmoid sinus. That shouldn't be there. And it's actually breached the outer cortex of the cranium. And blood is going into the diverticulum, swirling around and then coming out back and down into the towards the heart. And that creates a bruit that can be heard. Now, I perform 5, maybe more cortical mastoidectomies as part of different operations that I do. That means that I go through this bone into the ear about 5 or 6 times a week. And I never see any of these abnormalities in patients that other than those that have pulsatile tinnitus. So it is a condition specific to patients with pulsatile tinnitus. And I mentioned raised intracranial pressure. So I just want to dwell very shortly over a short period on why patients might get raised intracranial pressure. So there's a venous problem, so the blood can't quite get out of the head quickly enough. It has to be pushed out. And in being pushed out, the pressure in the venous system rises slightly. And as the pressure in the venous system rises, so does the pressure in the CSF compartment. So here the turquoise is CSF, and the CSF is produced by the brain. It has lots of metabolites that has to be absorbed into the vein to be cleared and cleaned in the liver. And so this CSF has to come out into and drain into the venous system through these little arachnoid villi and granulations. And it works down a pressure gradient. So the pressure in the CSF is higher than the pressure in the venous system. So the venous pressure goes up, so does the CSF pressure. And as it goes up, the patient starts to experience headaches, head pressure. And in some patients, it can get particularly high. So patients can have a condition called idiopathic intracranial hypertension, where the pressures reach over 25 centimeters of CSF. And occasionally, those patients can also have a condition called papilledema, which is swelling behind the eyes that can affect vision. And when the papilledema is present, then other specialties, including neurology, will start to take an interest. So looking at the data from the 800, this is a sample. These are patients who have got venous pulsatile tinnitus, and women are 6 times more likely to have venous pulsatile tinnitus than men. It's a female-dominated condition. It presents in women over a decade earlier, so they're young women that are affected, and they have worse symptoms. So this is a symptom severity score, very simple, 0 to 10, and women are affected more than men generally. Women have more idiopathic intracranial hypertension. This is a loose term. This is both with and without papilledema. So patients who've got pressures over 25 centimeters and their symptoms improve on reducing the pressure by lumbar puncture, then you can see that 22% of these females have idiopathic intracranial hypertension using that loose term. They're much more likely to have sigmoid sinus pathology, either diverticulum, 37%, or dehiscence or diverticulum present. And CT venogram is also an indirect way of looking for raised intracranial pressure. It's not the absolute test that requires lumbar puncture, but many of the patients will have symptoms or signs of raised intracranial pressure, either narrowing of the transverse venous sinuses, empty cellar, flattening of the globe. So typical signs from CT of a raised pressure. So I'm going to move on to centrally mediated pulsatile tinnitus. So the sound is created in the cochlea and is transferred by the auditory nerve into the brain. It goes into the dorsal and ventral cochlear nuclei. And then it passes across the brain, usually, majority does, through the auditory system up into the temporal lobe here, where you hear the sound. And with somatosensory tinnitus, this is a slide taken from Robert Levine's paper in 2004. One can see the inputs from the neck, the jaw, feeding in to the medullary somatosensory nucleus here, and then feeding into the dorsal cochlear nucleus. And it's thought there's a breakdown in gating mechanisms that allow both somatic tinnitus and somatosensory pulsatile tinnitus to then enter the higher centers, and patients can become aware of it. And these patients are slightly different to those who've got venous pulsatile tinnitus. So patients will often describe high pitch, so 50% low pitch or medium pitch, but 50% high pitch. So much more common in somatosensory tinnitus. And with this particular type, which I call somatosensory pulsatile tinnitus, they have a relationship with neck or jaw pathology. So when their neck or jaw issues are particularly bad, their tinnitus can be a little worse. And they can modulate it by opening their mouth wide, gritting their teeth, or pressing on their forehead, pressing on the top of their head, other maneuvers that cause muscles to contract. And it can change not just in intensity, but it can also change in character and pitch. So it can go from pulsatile tinnitus or constant tinnitus, or it can go from low pitch to high pitch or vice versa. But the important thing to remember is it is rare for these patients to be able to control their tinnitus by pressing on their neck. It's not very common, as opposed to venous outflow pulsatile tinnitus. There's a group of patients, a larger group, that do not have neck or jaw issues. They can modulate it by gritting their teeth, opening their mouth wide, or pressing on their forehead, or doing something, but they don't tend to have problems with muscle issues. And these patients, in my experience, are a little older. They are more likely to have some associated hearing loss. They will often also describe multitonal tinnitus, lots of other tinnitus going on in both ears, associated occasionally with sensitivity to normal sound. And there could have been a triggering event. So something happened that brought it on. They can remember some noise or sound that might have brought it on. All of these patients tend to have normal CT venography. So the difference between the two groups, if we look at these, this is venous pulsatile tinnitus and somatosensory tinnitus. I won't go through this in detail, but just to say that venous pulsatile tinnitus is predominantly in young females. Somatosensory tinnitus is more evenly distributed between males and females. Venous pulsatile tinnitus is more common in the right ear, and that's because the vast majority, not the vast majority, but a large proportion of patients have blood exiting predominantly through the right side, less so on the left. But usually venous pulsatile tinnitus on the side where blood tends to exit most out of the head. Not always, but usually. This is not the case, of course, with somatosensory pulsatile tinnitus, and so there's no side difference. Venous pulsatile tinnitus is low-pitched. Somatosensory tinnitus has 50%, is high-pitched. And it's the raised into venous pulsatile tinnitus is more linked to raised symptoms of raised pressure, somatosensory to neck and jaw issues. And if you do CT venograms on all these patients, which is my investigation of choice, you can see that venous pulsatile tinnitus have all the issues that we've discussed. It's rare in patients that have somatosensory pulsatile tinnitus. So I'm going to talk a little bit about managing. We'll start with the temporal bone just very briefly. So I'm a firm believer that ENT surgeons should be the primary care point for patients with pulsatile tinnitus, because we cover lots of areas and have a lot of interest in tinnitus generally. And so temporal bone pathology is quite easily picked up by ENT surgeons and will be treated appropriately by them. Centrally mediated pulsatile tinnitus. Is there a problem with the jaw or neck? And I know Mathieu talks a lot about managing somatosensory pulsatile tinnitus, so I won't dwell on that. Maybe there's some questions later. Objective pulsatile tinnitus. This requires careful investigation, and you do require cerebral catheter angiography to help in diagnosis. This can't be ignored. It needs to be investigated for the reasons I've given. If patients present, there's no objective pulsatile tinnitus. It's clearly venous because it can be controlled and it's low pitched. Then it's important those patients have an eye examination. I've seen a number of patients who've had papilledema that weren't aware that they had a problem with raised intracranial pressure. So all patients should have an eye examination. And if they've got idiopathic intracranial hypertension, then the best point of call is the neurologists who would hopefully perform a lumbar puncture and then treat you appropriately. But many neurologists aren't really interested in pulsatile tinnitus and not really interested in arriving at a diagnosis of raised pressure unless there's evidence of eye swelling, papilledema. And so it's patients will often come back to me saying that nothing was identified, and so we can treat the pulsatile tinnitus then. And this is based on different approaches. So a surgical approach for dehiscence can be resurfacing. It's a very straightforward operation, cortical mastoidectomy, and taking that bone and resurfacing the dehiscence with new bone. And that has a success rate in resolving or reducing pulsatile tinnitus symptoms by about 85%. And that's been published in other papers. This is our series in Cambridge, and it seems to respond pretty well to that treatment, and it's of low impact to patients with low complication. Diverticulum, this is a diverticulum here. You can see this is the sigmoid sinus, transverse sinus, this cortical mastoidectomy. You can see the diverticulum here where the blood is going in and circulating before coming out, and we can reduce the diverticulum, and in our hands, it resolves in about 60 to 70% of cases. But it's slightly harder than dehiscence, and there is a slight risk that you can over compress it. So one has to be thoughtful about managing this, and it should be done by somebody who is experienced. But there are alternative ways to treat both of these conditions, and interventional neuroradiologists have a particular interest or increasing interest in this field. Venous pulsatile or venous outflow was first described by my colleague in Cambridge, a chap called Nick Higgins. He presented the first patient in 2002, a lady who had raised intracranial pressure and narrowing across the transverse venous sinus. There's a pressure gradient from 21 to 8, so it's a high pressure gradient. And he put a stent in, pressure reduced, and the symptoms resolved. And there are, again, many studies looking at this. This is just one by somebody who has got a particular interest in pulsatile tinnitus, published in 2021 in the US. And he was treating all patients that had a pressure gradient across the transverse venous sinus of more than 4 millimeters of mercury, and got excellent results. Most patients had complete or partial resolution of their symptoms. It was a short review time, range between 1 and 34 months. In our experience, patients can get a degree of relapse, some patients, but certainly not all. So it might be that if looked at over a longer period, that might not be quite so high. So the last part, and it's just a quick part, I want to just discuss extracranial narrowing of the internal jugular vein. I left this to the end because it's quite controversial. Not as much has been published on it. We have, and increasing papers are coming out, but it's looking at the internal jugular vein. Blood comes out through the head, and the majority of it, about 75%, enters the internal jugular veins. And most patients, or most people, have lots of different routes of blood to get out of the head. The internal jugular veins are just one. And for some, however, the internal jugular veins are incredibly important for getting blood out of the head, and especially a small group can have just one major vein, internal jugular vein, that's getting blood out of the head. And that is incredibly important to the patient for managing venous outflow. And if there's compromise of that or narrowing, then they can get symptoms of pulsatile tinnitus. So this is going to be taking you through a CT venogram from the top to the bottom. It's a short movie, but I'll point it out as we're going. So we're going to look first at the right side, which is this side here, and then we'll play it again at the left side. So we're going to look at this vein here. This is a sigmoid sinus. I'm going to see it going through the temporal bone. So here we go. So it's running through the temporal bone, sigmoid sinus, coming into the jugular bulb here. And there it is, nice and big. But then it gradually narrows down, styloid there, transverse process there, and then it disappears before then opening up as we come down here. So that's been narrowed. And if I play it again on the left side, blood's coming round into the jugular bulb, internal jugular vein, and it's coming down and it gets nipped at the transverse process C1 vertebra. And I just want to, as a result of that, this patient requires alternative blood flow out of the head. And so blood's coming down through there, and then it can escape through different routes. Here it's coming through other veins to get out of the head, take an alternative route, and that's causing pulsatile tinnitus. And you can see here nipping of the internal jugular veins over the transverse process. Now, I mention it with reservation because I see a lot of patients that come with concern about their internal jugular veins as a cause potentially of the symptoms they're experiencing. Many patients with pulsatile tinnitus and lots of others with other symptoms. And 30% of patients have narrowing of their internal jugular veins, but they don't have symptoms. This is a normal finding, and one has to be extremely careful to place symptoms at the door of internal jugular vein narrowing. One has to be very careful about arriving at that diagnosis, because otherwise patients will have surgery and will see no benefit from that operation. I've been there. So here, this isn't a case where there's been nipping of the internal jugular vein between the styloid and the transverse process on both sides. And this is surgery where those veins have been opened up and the styloid there taken out. And these patients do get some benefit, not all of them, some only mild benefit. It's quite a complex area to consider. This is our series here. So conclusion, it's very important to spend time arriving at a diagnosis, listening to the head with a stethoscope, checking the hearing. This is all in the ENT area to start with. And then if there's evidence of raised intracranial pressure, the eyes must be checked to see if there's any papilledema, and then treated appropriately by the neurology teams. The patients can be treated in lots of different ways, as discussed, and patients do well with surgery if the symptoms are purely pulsatile tinnitus. The intervention is quite mild, and there's lots of people out there that are doing that kind of intervention. Stenting can certainly be considered. I certainly find it most beneficial if patients have also got symptoms of raised intracranial pressure and haven't responded to conventional treatment. That's very important. Then patients need to be treated with conventional medications first to see whether they improve. And one has to be, once again, very careful about arriving at a diagnosis of internal jugular vein stenosis. Many people have it, and it's only rarely the cause of the symptoms. And I've mentioned central causes earlier. So thank you very much. I'll hand over to Mathieu and any questions.
Thank you so much, Dr. Axon. That was fantastic. What a fantastic presentation. I hope everyone enjoyed this. If you did, please put some applauses in. Yeah, raise your hands or show something in the chat. Thanks a lot. We can see a lot of raised hands. That's great. That's great. Okay, so just to take a short break before we go into questions, I just wanted to run a quick poll and just see how many of you, now that you've heard so much about pulsatile tinnitus, think that this is something that you're affected with. That will be an interesting kind of little experiment here. So I'm just opening up the quiz. If you want to have a quick answers. Thank you. I can see them come through. Great. Yes. And while we're waiting for those results, please remember to put some questions. We'll go through the questions in the next 10 minutes. We'll try to keep everything within the hour. All right, so about everyone now is come through. Wow, that's a perfect 50%. 50%. Half of you guys think that you've been afflicted with pulsatile tinnitus. That's a very interesting number. Thanks for sharing that. I'm gonna end the poll now. I think it's pretty accurate. That's great. It means that it's a big problem, as Dr. Axon mentioned. It affects a lot of you, and it's something to consider, especially if you're early in your journey with the tinnitus. Always, as Dr. Axon mentioned, your journey with tinnitus should always start with some kind of medical practitioner evaluation. And by that, I don't always mean audiologists. Audiologists are part of that, but you should always get your ears checked. You should always get your neck and jaw listened to for objective tinnitus signs that can be sometimes treated. So it's very important to do that work. However, if that happens and you don't get anything from that, there is nothing underlying the tinnitus or explaining the tinnitus, it doesn't mean that you should give up hope. There are very effective ways to manage the impact it has on your life. So don't give up when that happens. That's also a message of hope. You guys that have been involved with MindEar before know that we like to promote hope and try to give you always the best techniques that are available to manage the symptoms. One of those that, if you missed the beginning of the call of this webinar, is the new group session. So I'll just quickly share my screen again just to show those QR codes if you want to have a look. So this is really much what I'm talking about. So we're doing group sessions now. These group sessions are very, very effective at putting a structure around the different techniques that we have seen and evidenced in science or by science to help with manage the impact of tinnitus. This is in the case where you've been through all the medical checks, you've been to your ENT, and you've found that there is nothing underlying your tinnitus. You have chronic tinnitus that has some impact in your life. You want to find, the most effective ways to manage that impact. You can come up with us, and we'll help you go in depth into those topics, and also get you to meet other people and share tips and tricks on how to do that effectively. These sessions include sleep management techniques, mindfulness for tinnitus to manage, the stress and anxieties coming from it sometimes, neck and jaw tension tips, because that can sometimes be a trigger or contributing factor. And then also going into a very specific sound therapy sessions where we talk about mixing points, how to use sound therapy effectively, and how to maximize its effectiveness. And finally, cognitive behavioral therapy, which is very effective at changing our reaction to the tinnitus, but also can be applied in other aspects of our life and make us happier in general. So here is the QR code. If you'd like to kind of sign up and try it, this is money back guarantee, meaning that the first session, if you do it and you don't like it, we will reimburse you for sure. And for the app, you can always download the app and go through this experience, this journey on the app. This is self-serve. You can go through all the steps, learn at your own pace, and also benefit from the content that I've talked about and the techniques that I've talked about. All right, so this is the end of this little sharing session. So I'm going to be going through questions and asking your questions to Dr. Axon. Hopefully we can come up with some answers that you find useful. Let me see where's my Q&A screen? All right, so obviously people, thanks for Dr. Axon can see in the chat as well that you've been enjoying his presentation. So okay, let's start with the first question that was asked. Dr. Axon, Isabel tells us that she has been experiencing pulsating sound, but from external noises, a running fan or motor vehicle passing by. When this happens, her ears feel blocked. What might this be? So that's an interesting one.
Yes, I do hear patients mention that sound can be a trigger for pulsatile tinnitus, and I think Isabel mentioned lower down that she also has multitonal tinnitus as well. I think, as I say, with these specific questions, and I'm answering them without examining you and looking at things. So I'm being put a little bit on the well, I don't have all the information, but in those patients, they'll often describe complex tinnitus that can be modulated by performing maneuvers around the jaw or the neck, and will often describe other issues with the jaw and neck, and point towards a centrally mediated cause. It's very rare that an external sound will upregulate venous pulsatile tinnitus, which is the most likely cause for patients with pulsatile tinnitus.
That's thanks for that, Dr. Axon. And I think what you're saying is that everyone is different. So obviously, when we answer these questions, make sure that you make sure that they apply to you. So always take this information with a grain of salt. Go back to see your ENT, get checked again. Maybe come up with you're the best advocate. When we even at MindEar, when we talk to you for half an hour, we can't understand the full extent of who you are, all the complexities of your tinnitus, but we will do our best to point you in the right direction, always provide you with the most accurate information we can, but always take that and go back and try to be as open-minded with your medical practitioners, try to present that to them and see if you can all come up with the best answer for your problems and your journey. Okay, so next question from Susan. Can you have random pulsatile tinnitus? And I think Susan means at random times and not all the time.
Oh, very, very much so, yes. So patients can become aware of pulsatile tinnitus when it's particularly quiet. They might hear it more when they lie flat because of the change. The change in posture can change very slightly the flow of blood from the head, so it can become either slightly louder or slightly quieter. When patients exercise, it can become louder or quieter. When you talk about randomly, it's sort of more difficult to say why that would occur. Objective pulsatile tinnitus is there 24/7, so it's unlikely to be that. But there can be many triggers, and as mentioned, also with jaw and neck issues, if they're particularly bad, then it can be triggered by that. So I think that's about as much as I can answer that question.
Yeah, thank you. That was great, and I think the summary of this is make sure that maybe it's not that random. Maybe there are some underlying patterns that you haven't pointed to. Maybe it's how the way you sleep, the bed you're sleeping in, the position. Maybe when you're at work or when you're standing or sitting somewhere, after a while it just triggers some kind of pain in the neck or jaw, or maybe you've been grinding your teeth that night. Things like that can happen in the background that maybe we don't always notice, and could be contributing factors to your tinnitus and make it seem random, but it's actually not that random. But obviously, again, this is a generic answer. It needs to apply to you as well. So yeah, hope that answered your question, Susan. Okay, now to John. So John, I think I saw this question come up in the context of the IGV stenosis part of the presentation. So John was saying, my pulsatile tinnitus gets louder when I open my jaw, and is asking himself, is that the reason IGV? So intrajugular vein stenosis, if I'm correct. So could that be the reason?
So I think that unlikely. If you're opening your jaw, and opening the jaw is the only movement that can alter your tinnitus intensity, then it's most likely going to be centrally mediated. If you open your jaw and you can stop it by pressing on the neck, specifically over the internal jugular vein, then there might be a venous cause. And I've had some patients who can open their jaw and the tinnitus reduces, as well as pressing on the neck. It's likely still to be venous. But if it's purely opening the jaw wide, then it is more likely to be centrally mediated.
Great, thanks. Thanks for that. That's very precise and very helpful. Okay, now I'm going to move a bit faster because we've got many questions. I'm not sure we're going to be able to go through all of them, so I'll go a bit quicker. So from Robin, is there an explanation for why the type of sounds can change daily? That
So
that yeah, that's not really necessarily in the context of pulsatile tinnitus, I guess, but yeah, maybe you can give us a short answer for that one.
most people will describe it as one particular noise. They'll say it's a whooshing or a thumping or a banging. So it doesn't tend to change in character unless the underlying cause is centrally mediated. So patients will do certain things that change head posture or jaw. And as I mentioned in the presentation, those maneuvers might not just increase or decrease the intensity of the tinnitus, but it can also change the pitch and character. It can move from a pulsatile to a constant tinnitus.
So many factors can contribute to the change of the sounds. Depends on, so many contributing aspects that it's really hard to sometimes pinpoint. But as Dr. Axon said, it's most of the time going to be one specific sound. So yeah, it depends. Thank you, Rosa. Have a good day. So Rosa said, thank you so much. Fantastic presentation. We're running in the hour, so I'll try to find a couple. We're going to answer a couple more questions, and then we'll say goodbye to Dr. Axon. So another question. I hear blood whooshing and notice that when I take a bath, the tinnitus disappears and reappears about 10 minutes after a bath. It does this every time. Why do you think this would be? It's a very
So
interesting one.
So when you have a bath, usually the bath is hot, your vascular dilates because you're in a warm environment, and so blood circulation changes very slightly. And so that might be just enough to stop or change the blood flow to a slightly different direction, and so the tinnitus stops.
Yeah. Okay. Thank you. That was great. Then we have Nasir. As an audiologist, there is often greater emphasis placed on unilateral tinnitus as opposed to bilateral from a perspective of the need to refer to an ENT. Why?
So unilateral tinnitus can occasionally be also associated with hearing loss. If you've got a hearing loss, then the concern is you might have something called retrocochlear pathology. And the most common retrocochlear pathology is a vestibular schwannoma. So bilateral tinnitus is unlikely to be the result of a benign growth in the ear, vestibular schwannoma. I noticed further down, Matthew, there's a question about what about vestibular schwannoma. I did have a slide on that, but I removed it for time. I've only got one patient that had a vestibular schwannoma in all my investigations for patients with pulsatile tinnitus, so one in over 1,000. And I think that possibly was incidental. So a lot of people get scans and you find an incidental benign growth. So I wouldn't put emphasis particularly on a vestibular schwannoma, but the reason why we as ENT surgeons take a particular interest in unilateral symptoms is because we don't like a difference between the two ears. And if there is, especially associated with hearing loss, then we want to get an MR scan to exclude a vestibular schwannoma.
Yeah, and it's the simplest, it's the lowest level of filtering to having a possible unbalance or something happening in the abnormality of the ear organ. So it's a very simple filter that can happen at the clinical side on very early stages of the journey to tinnitus care, and that's why it's often put into a little bit more light. Okay, thanks. That was great. And then maybe a last one. So I saw a question from Chris that says, "Thanks for the interesting presentation. I've had pulsatile tinnitus in one ear since an ear infection in that ear. So I'm wondering, are there any times of pulsatile tinnitus that often arise from an ear infection?" Which I think that's an interesting question.
Yes, so if somebody was to describe that to me, I'd certainly be wanting to have a look at the ear and get different types of imaging, depending on what I find. Is there associated hearing loss? And so I think that's why I emphasize the need to be seen by an ENT surgeon, because sometimes people can find things within the temporal bone that are causing the symptoms and possibly the infection. So if you haven't seen an ENT surgeon, then I would suggest that you do see one.
And I would say it's the same for Paul, which asks, can radiation treatment for pit tumor affect pulsatile tinnitus? So it's probably similar aspect.
Yep. So I wouldn't know the context in which the radiotherapy was given, but yeah, I think that one, if you're concerned you've got a new symptom following that, then you should be seen by the appropriate doctor.
All right, I think we're going to close the questions now. We're 5 minutes over. So thank you very much, Dr. Axon. I think that was a great presentation. We went through a lot of content and a lot of questions, great questions. Thanks for to everyone for interacting and asking your questions. This is always for your benefit as well. We hope that you got as many great insights as we did. I did personally. I learned a lot as well today. So I thought that was a fantastic. Please share your thank yous and love on the chat, and I will see you very soon. Reach out to us if you need any help. If you don't have pulsatile tinnitus and only chronic tinnitus or chronic tinnitus and you need help managing this, just reach out to us, download the Mindy app or connect with us regarding the group sessions, and we'll do our best to help you with this. Thanks, everyone. Have a great day. Bye-bye. Bye,
Okay.
Dr. Axon. Thanks a lot.